sides we have seen so far. So one side I am going to demonstrate here, and I am going to show you certain positive findings in this case. This particular patient, he has a pansinusitis. This is pure eosinophilia. And see this. Frontal, hardly any challenge. Good frontal sinuses. This is beak. This is frontal drainage. See the turbinates. Can you see? Hello? Turbinates, lateralize, and a lot of disease medial to the turbinate. Again, can you see this?
Yes, sir.
That is something. Once you have a disease medial to the turbinate, you have to, resect it partially to give access to the topicals to reach inside the olfactory region and other areas. So this is one. Number two, see, almost white out. I can see optic nerve all in place. Nothing is lot of polyposis. So nothing much to comment a regular one. We have already discussed the things this patient has already in the previous cases. So this is a rehearsal of what we have been doing in the previous cases. What I can see, the turbinates, a lot of disease medial to the turbinate. Massive. See, you have to see quickly the challenges one can come across. That is important. Any bone erosions outside, any breach in the walls. See the anterethmoidal artery, which is should be prominent. There is a cell above the level of the ethmoidal artery between the space between the artery and the skull base. Can you see? So you have to be careful at this point, because your artery is running below the level of the skull base. One can damage if not careful. Level of the orbit and the medial wall of the maxilla. Good. Hard. Some septal deviation on this side you can see. See this? Will require a limited septoplasty like previous case. These are all ethmoidal cells, anti-ethmoidal cells. Little bit of the supraorbital recess like this. Not much. Not like the first case who had big supraorbital recess, but it is a shallow supraorbital recess. And the frontal, the big frontals. And this. So let's quickly. Any questions? Hello.
Sir, right frontal drainage, can you describe, sir, please?
Right frontal drainage is hardly any challenge. See, that is the challenge is that ethmoidal artery, important finding, supraorbital recess anterior to it, frontal sinus. See this, anterior to posterior, how to go. See, this is anterior most. Now I am going posterior. First thing is the frontal. See now, first thing is the frontal sinus, anterior to posterior, frontal sinus, and the floor is made by beak. Sinus, floor is made by beak. Now the beak has gone. This is how we open the frontal. Go along the beak where the beak ends, behind the frontal. Can you see now?
Yes, sir.
That is the point. Now frontal has gone. The anterethmoidal roof has come. See, I am going behind anterethmoidal roof. Cribriform is there. Coming behind. Now behind is the anterethmoidal artery. See how far behind it is.
Yes,
Got my point?
Yes, sir.
Frontal sinus, the beak has gone. This is more than a centimeter behind the beak. Don't terrify. And now once the artery is gone, now see the posterior roof starts. Flat,
Yes,
more
sir.
flat. See the more thicker, more flat, and the posterior artery running through it, through the thick bone is rarely visible, rarely prominent. Because this roof is much thicker than the anterethmoidal artery where it runs to the anterethmoidal roof. Okay? Now this is again the post-ethmoid. Now, where the sphenoid starts, see this. This posterior ethmoidal roof is formed by all the way by this frontal bone. Can you see? Terion to terion, this entire frontal bone is forming the roof of the ethmoids. Now, if I go behind, now I am going behind. Now see that frontal bone is gone, and this is the lesser wing of the sphenoid comes. When lesser wing of the sphenoid comes, below is the sphenoid sinus.
Yes, sir.
Now it is sphenoid sinus. Okay, that is the optic nerve. That is the depression of the optic nerve. So this is, this is sphenoid process. This is optic nerve, orbital apex. This is superior orbital fissure. And if I am coming anteriorly, see this is sphenoid. Now
there
this is
nodicals?
post-ethmoid. Now this is post-ethmoid again.
Is there a nodicil left on left side?
Onodi, yes, looks like. See how to see in dynamic imaging onodi. Let me reconstruct to all three planes. Onodi means one of the post-ethmoidal cell is going behind and above the sphenoid. This sphenoid sinus, and see this is proper sphenoid sinus, smaller one on this side, the bigger one on the opposite side. And this section is right at the level of the intersphenoid septum. It looks like a small cell. This is the bigger one. This is opposite sphenoid. This is left side sphenoid, smaller one. See this smaller sphenoid. So I don't see any onodi kind of a situation here. It is crystal clear. The sphenoid is rather smaller. And you see, this is the level of the posterior septum. See, posterior septum, here the rostrum forms. And here close to the rostrum, see this, close to the rostrum, you have to enter into the sphenoid. Just along the septum. That is the best way. You cannot disorient if you go along the septum. So can we start now?
Yes, sir. Sure, sir.
This patient has massive eosinophilic disease, massive polyposis, and now you must have tired by now this morning. So this is going to be the last case for before the evening party.
We are not tired, sir, when our teacher is not tired.
I know, must be tired.
While entering the sphenoid debride. Septum की debrider का अपना blade should be towards instead of enter करते हैं away
Toward the septum.
towards the septum.
Medially safe, है ना?
नीचे.
Can you change to the endoscopic picture? बोलना. Hello?
Yes, sir.
Are you getting the endoscopic picture?
Yes, sir. Yes.